A very good morning to you all. Welcome to this, I think we are already 15 minutes late. Welcome to this session on Ectopia Lentis, the subluxated cataract, which you have been running for quite some time now in AIOS. And we have a galaxy of speakers. Dr. Priya Narang, Dr. Chitra Ramamurthy will be speaking on management strategy. Priya would be speaking on IOL options. We have Dr. Shuja Gupta will be speaking agonies and ecstasies. Dr. Siddhartha Ghosh will be speaking on traumatic subluxation, and Dr. Arup Bhomik will join us to speak on extreme subluxation. They are already there in another session. Myself, Dr. Ajoy Paul, will be speaking on the emerging technologies. I would invite my first speaker without waiting, Dr. Shuja Paul, the Chairman, Scientific Committee of West Bengal Ophthalmic Society, a prolific surgeon, a teacher, has experience both in India and UK, and he will be showing us the assessment and decision making. Yeah. Over to you, Shuja. I would invite my co-speakers to co-instructors to be on this stage. Dr. Priya, please. And Dr. Surya. These are the two which are there.
Good morning, everyone, and thank you, Dr. Ajoy Paul, my mentor at OSWB, for giving me the opportunity to speak here in this prestigious instruction course. I'll be speaking on assessment and decision making, where the beginners have their dilemmas in managing ectopia lentis. So we all know that the zonules are microfibrils which actually suspends the lens 360 degree. It extends from the ciliary body to the anterior and posterior capsule in the equatorial region of the lens. And when there is some loss of the zonules or weakness, we get the dislocation of the lens, subluxation of the lens. And when the lens is completely outside from the lens patellar fossa, we get what we call dislocation of the lens. The beginners can have dilemma in diagnosing, in management, in preoperative assessment, and which surgical technique to choose from. So to diagnose any case, we need to know the etiology, and trauma is the commonest etiology of ectopia lentis. The good thing is that the trauma, zonular dialysis or zonular weakness is non-progressive, whereas there are other conditions which are primary ocular disorder associated with ectopia lentis, hereditary ectopia lentis without systemic disorder, and there can be systemic disorders which are associated with ectopia lentis. The ocular conditions which are associated with ectopia lentis can be congenital glaucoma, retinitis pigmentosa, pseudoexfoliations, aniridia, and also high myopia and hypermature cataracts. Whereas systemic conditions which are associated with ectopia lentis can be Marfan syndrome, homocystinuria, Well-Muscrini syndrome, and also Ehlers-Danlos and few other causes. And you have to know, the beginners should know that in where the lens dislocate, like in Marfan's, is dislocated superiorly, in homocystinuria is inferiorly, and in Welsh-Muscrini it can move forward and can cause complications such as angle closure or pupillary block glaucoma. Now, we need to know the causes of decreased vision, which can be due to fluctuation of the lens into phakic and aphakic position, due to significant hypermetropic or myopic shift, and also monoocular diplopia. And there can be loss of accommodation as well. And the complication, as I have already said, can be pupillary block glaucoma due to forward movement of the lens and endothelial cell loss. So a beginner should take good history in cases of systemic diseases, also take history of ocular trauma, skeletal problems, history of familial problem like consanguinity, mental retardation, and unexplained death in the family. And they should do a thorough ocular evaluation extending from the full BCVA to anterior segment examination, including gonioscopy, which is very important in this situation because there can be trauma-related problem, there can be angle-related problem in congenital cases, and also detailed fundus examination is very important. And if you are planning surgery, then evaluate the lens position, the degree of the zonular loss, and try to see if there is any vitreous in the anterior chamber. And other investigation as advised by the pediatrician in cases of congenital cases. So where the dilemma in the management? The main dilemma in the management is whether to manage it conservatively or whether to do surgery. Now, conservative management can be done when the refraction is stable. You can prescribe glasses or partially occluding contact lenses. And in some cases, you need to do laser iridectomy if there is chances of pupillary block or angle closure glaucoma. And surgery is required when the fluctuation of the power is there, refraction is there, whether there is lens-induced glaucoma, there is cataract associated with ectopia lentis, and when there is impending dislocation of the IOL, of the lens, sorry. So what the dilemma in the surgery? Any beginner should know how to grade the subluxation. It can be graded in different way. If you dilate the pupil and if the aphakic area in the pupil is less than 25%, or whether it is from 25 to 50%, or whether the lens is subluxated in such a way that the aphakic portion is more than 50%, this is one way of grading. The other way of grading is according to the zonular clock hours of zonular loss, such as mild when there is less than 3 clock hours loss, and it can range to advanced when there is more than 9 clock hour loss of zonules. And all the beginners should be familiar with these rings and hooks and segments so that they can use it in the right way. So the capsular hooks or the iris hooks, they aids in the rexis completion, aids in the CTR insertion, and also during the phaco it gives stability, and also during the IOL insertion. These give transient or temporary and support in the anteroposterior support, whereas the CTR, they expand the capsular equator and buttress the area of the weak zonules and stretches and tautens the posterior capsule to enhance the PC safety, and also it recenters the mildly subluxated IOL in the bag. Sometimes you can get away without fixing the bag in mild subluxated lenses and decrease PCO chance as well. And the size of the CTR, we should know how to choose the size. It actually depends on the axial length of the globe. And the beginners should know when not to use the CTR, such as in anterior capsular tear, in posterior capsular rent, in incomplete rexis, and in severe subluxation. CTR will not help. We need to fix the bag in those situations. And here comes the role of the capsular tension segments, where we need to know that there are right segment and left segment. We just cannot just invert the CTRs because because this area which is fixed over the capsule, anterior capsule, is in a slightly is it in auto forward mode or what? It is slightly in a superior plane than the normal segment, and it goes above the capsule. So we choose the surgery according to the zonular dehiscence size. If it is superior up to 4 clock hours, you can use CTR, or you can sometimes get away with just implanting the IOL with the haptic being used to stretch the bag. But in cases of inferior dehiscence, you have to either use CTRs if it is less than 3 clock hours. You can choose modified CTRs or segments if it is more than 6 to 9 clock hours. And if it is greater amount of subluxation, then you can also consider sacrificing the lens capsule and arrange for scleral fixated or iris clip or anterior chamber IOL. And you have to, the beginners should be familiar with all the techniques and can take the help of his retinal colleague if vitrectomy of the sublens if it is dislocated in the vitreous, or fragmatomy if it is a hard cataract. Few tips of do's and don'ts. Always try to maintain main incision away from the zonular weakness. Try to initiate the rexis away from the zonular weakness. Use high molecular weight viscoelastic to plug the vitreous away. And it is better to use micro capsular rexis forceps. They are preferable in these situations than needle. And you can use the technique which don't put stress on the zonule mass. All this will be discussed by our speakers, in the eminent speakers, in the next few seconds. So beginners should be aware of the complication, post-operative complications as well, so that they can manage them if and when required. So in conclusion, subluxated lens need a good thorough pre-op evaluation. Surgical plans has to be individualized and long-term follow-up is required. For the beginners, they should attend instruction courses, observe and assist the experts, to gain more insight and confidence, and they should, when they start operate, ideally they should start under supervision. Thank you very much.
Thank you, Dr. Shuja Gupta, for giving us a nice insight into how a beginner should begin with. Now, what do you think the first cases should be for a surgeon, and with how many experience and how many years or how many cases he has done, especially putting in a CTR? And CTR is the first thing they would all.
So I would say in cases of putting CTR in subluxated lenses, they would first put CTR in patients who are non-subluxated lenses, like in high myopia, where it's quite easy to put the CTRs, and they should learn the technique. Similarly, same thing, they should try putting the capsular hooks in normal cases, in few cases, so that they can do it quite easily and efficiently when they get a subluxated lens. And for a subluxated lens, if I had to choose, I would choose a patient who has minimal subluxation in the beginning few cases, not to go ahead with a subluxation which has quite a lot of subluxation.
Yeah, and again the salvage mechanism, and when this fails, what next? I mean, they should be aware of doing an aphakic patient, whether they will do in the second stage or first stage, or I think the IOL option would be spoken to us by Dr. Priya. Means in case you fail, I mean, get ready with the SF IOL, get ready with glued IOL or Yamani, whatever technique, I think. Thank you, Dr. Shuja Gupta, for giving us.
Thank you for
I think the next speaker was supposed to be Dr. Chitra, but she's stuck up in another hall. Dr. Siddhartha will speak to us on from ectopia. Basically, either it's progressive or it's stationary. So here we have traumatic cataracts, where traumatic subluxation, where it can be vitreous in AC and how you intervene. I mean, he will be speaking us. This is basically non-progressive type. Yes, Siddhartha, please.
Good morning. Thank you, Dr. Ajoy Paul, for including me in this prestigious course. Well, in the next few minutes, I'm going to talk about traumatic subluxations with or without vitreous in AC, and when and how do I intervene, what are the principles. Let's look at the, situation. We are talking about the lenses. These are, displacement or malposition of the crystalline lens of the eye, and most of the ectopia lentis, the commonest cause is trauma. That happens to be the commonest cause of ectopia lentis. Well, what are the principles of management? Two questions basically. When to intervene? We only intervene when vision is affected or the integrity of the eye is affected. And how do we intervene? We need to tackle the vitreous first if it is there in the AC. And then we need to understand that we must try to preserve the capsular bag as far as possible, and judicious implantation of IOL whenever possible, and depending on the expertise of the surgeon and depending on the situation. Let's go straight to the videos, and this is the first one. As you can see, the here the whole lens is in the AC, and vitreous attachments are there in the posterior surface of the posterior capsule, and when we really do vitrectomy, you'll see it's pulling the posterior capsule. Here, as you see, the when we do vitrectomy, anti-vitrectomy, it's pulling the posterior capsule here, and unless we take away, we sever all the attachments of the vitreous with the lens, it will not come out. So to reduce traction, what we do is we use a do thorough vitrectomy and then take out the lens with a vectis. As you can see, we have taken it out in toto, and then do further vitrectomy if needed. You can see a small iododialysis at 6 o'clock here, and well, after we do this, we need to implant. Now, these are special situations where there was a trauma, it got subluxated, dislocated, and hypermature. It became hypermature, it leaked all the fluid, and it has come spontaneously to the AC. Now, these are very easy to remove. As you can see, it's it's very simple. You can straight away remove them and then do vitrectomy. And then we would prefer in these cases, in this particular case, we planned a glued IOL. So we made two opposite scleral flaps, and we make entries to go inside, do vitrectomy, further vitrectomy, and then fix the lens. This is how we do the vitrectomy, and then we go ahead, we implant the leading haptics, and once we catch hold of the leading haptic, tip of the lead, we exteriorize it, and then we go to the second haptic. The trailing one is also exteriorized, and thereafter these haptics are tucked into the preformed channels in the sclera. Now we can also do it by putting a AC maintainer that helps in stabilizing the AC actually, and while exteriorizing these haptics. Once we exteriorize them on both sides, we will tuck them in the preformed scleral channels and then use glue to close the the scleral flap and the conjunctiva. This has been popularized by Dr. Agarwal, and it's very popular with most people. And there are other techniques as well. We can use these simple iris claw lenses. It needs to be retrofixated to the iris, and just a little tucking of the iris in the the claw with the iris clip lens, these are called, and we just need to tuck, enclavate the iris in the proper haptics, and then you can just take out. It maintains it stays in the physiological space, and this gives good results as well. In certain situations where we know there is a small subluxation and there is no vitreous in the AC, so we go ahead. But we need to remember that even if we go ahead, our manipulations, when I did the Rexis, it was little wobbly, so I thought I'll put the CTR initially. It is really very wobbly then, and once I finished putting the CTR, what I notice is there is some amount of vitreous in the AC. The liquid vitreous has popped out because of my manipulations. So here again, it's important that we do anti-vitrectomy to clear off the vitreous and then go ahead. These videos are playing a little slow, so I'll go ahead. And then you go ahead with the procedure and we implant a lens. Well, we'll go to the next situation. This video is courtesy Dr. Devashish Datta, my good friend, and he has very elegantly shown that you can stain the vitreous with triamcinolone and then go through the pars plana route and do a vitrectomy properly, and then once we do a pars plana root vitrectomy, we clear off all the vitreous in the AC and then go ahead with the procedure as we have just discussed. Here again, this was extreme, subluxation, where, as you can see, there are pigments on the anterior capsule, and but there was no subluxation here, as you see. But there is a history of trauma here, blunt trauma. But once we go ahead with the surgery, we need to understand if there is a history of blunt trauma. We need to be very careful. No very rapid or massive manipulations inside that can lead to further zonular dehiscence. And as you can see, towards the end of the surgery, the bag really comes, a lot of, the whole bag came out kind of. So you can push them back with viscoelastics and fix the bag with the sclera. Well, for sake of time, we will not discuss all. These are extreme situations where you need to do vitrectomy, lensectomy, and also repair the iridodialysis. Thank you.
Thank you, Dr. Ghosh. Excellent. Any question from the audience? Anybody would want to ask anything? Okay, so my question I have for you is, when do you decide that you need to do a vitrectomy first, and when do you decide that whether it is anterior or posterior? I'm not saying that there's vitreous in the anterior chamber. You can go ahead and start. Is it ready? Okay, fine. So when do you decide to do a PPEV, and when do you decide not to do a PPV before cataract section?
Right. See, if we have vitreous in the AC, it's good to do a PPV ideally, so that if there is a small zonular dehiscence and there is small subluxation, you have vitreous popping in the AC. If we want to do anterior vitrectomy, what happens? It might pull further vitreous and damage more of the zonules. So it's best to go in the pars plana route, cut all the vitreous that is there, and the whole thing, you know, so you are saving the other zonules. If you keep pulling, you may damage further zonules. So it's best to do a PPV and then start the cataract procedure.
Okay. Thank you, Dr. Ghosh. Next we have, I don't think Priya needs any introduction. So she's going to talk to us about IOL choices in Ectopia Lentis. Priya, whenever you're ready.
Yeah. So, good morning, everybody. Thank you, all of you, for being here. And I would like to thank Dr. Ajoy Paul for inviting me to his instruction course. So, well, I will be talking upon the IOL choices that you can go ahead in cases with Ectopia Lentis. Actually, and the previous talk has covered quite a bit of it. So, let me go ahead and see what I can show you a bit differently. I can emphasize on different aspects. So we all know that, you know, the basic thing that whenever you have a dislocation of the lens or a subluxation, whenever it's partial, we call it as a subluxation. We all know that. And if it's total, it's a dislocation total. Our management actually depends on what situation is there inside the eye, the clinical scenario. My clinical choices, they come up very clearly whether this is, the first thing that I see is whether it's a progressive or a non-progressive zonulopathy. So the entire management goes on to that. This is the most important diagnostic criteria which I use for performing the surgical procedure in a case of Ectopia Lentis. You might have various degrees of subluxations. You might have a minimal one, you might have a moderate one, you might have a severe one. But if it's a progressive zonulopathy, I do understand the aspect that it's very important to keep the bag as much as possible, but when it's a progressive zonulopathy, suppose even if you repair one segment, the other segment is going to go off within few years, maybe 1 year, 2 years, 3 years, or depending on how fast or progressive the zonulopathy is for that particular case. Because we have seen many cases, you know, coming up with the implantation of endocapsular ring segments, etc., and everything getting dislocated over a period of time. It's just a matter of time when you have a complication out there for your patient. So this is a very important aspect that comes up. Now, if you have this kind of, the choice of intraocular lenses, actually then again it depends how you are handling your case, whether you are using a one-piece or a three-piece foldable intraocular lens, and there are various segments which have already been discussed, so I don't go into this. A subluxated lens, okay. So this is a case that you are seeing, it's a mild subluxation. So what you see in this case is that, you know, it's a cataract, mild subluxation going on. There's a history of trauma in this case. So there's nothing much to think into this case, except that when you have taken up this case, you need to assess, you know, how much is the dangling movement coming up from the lens in itself. Because the moment you inject viscoelastic and the moment you do a capsular access, things quite, they become quite clear. You know, you will assess the movement of the lens which is there at that point of time. And then, you know, the second important thing here is putting up a capsular tension ring. Many surgeons want to put it up right in the beginning because they want to support whatever system is there into place as it is. Some of the surgeons, they like to go in the intermediate stage, you know, when you have created some space in the capsular bag, then you want to put it. And some surgeons, they go at the last, that okay, when we are done with the entire removal and if it's not moving much, the lens is quite stable, then let us do it at the end, because then you do not have any trapping of the cortical matters coming up with the capsular tension ring. So this is all surgeon dependent. You can use, you can put the ring whenever you need it in cases of mild subluxations. They do very well. Again, coming up to the intraocular lens, again, it's a surgeon's choice. There are many surgeons who want to go ahead with a one-piece. Many surgeons go ahead with a three-piece. Totally your choice, whatever you want to put into the capsular bag, because everything is going to remain stable out here. It's a minimal kind of thing. The only thing is that, you know, many times many times I consider putting up a three-piece intraocular lens, not because that, you know, it is specifically indicated, but just because that if there is some another complication coming up in the postoperative period, you don't have to open up the eye. This same intraocular lens can be intracellularly fixated, and you can go up with the case and it can be settled down at that point of time. Now, actually in this case, there is also the iris has gone off. So the procedure of choice that was described by me and Dr. Agarwal was the single pass 4-through pupilloplasty procedure. And this is our surgical procedure of choice when we go ahead with doing a pupilloplasty procedure. Simple, fast, easy, and it works superbly. It does not have a knot. It has a self-sealing kind of knot which just lies very close to the surface of the iris, and it works really well. So this is how you settle down with this. Coming up to something which is much more. bigger, larger. It's a progressive zonulopathy. Yeah, now there are various options again onto this. I would, I mean, like surgeons would like to do a REX is, you know, putting up ring segments and then doing it. Looks great. Results are also great. I don't deny it. But when it, such kind of cases, when they come to me, I tend to go in with lensectomy because taking into consideration, suppose for the patient, for the lifelong, I think I try to go ahead with the intracellular fixation for these kind of cases. So now this is a case, so what actually we do in these kind of cases, you know, we go ahead with intracellular fixation, so 2 partial thickness scleral flaps are being made. Now, you can go ahead with any technique of your choice. Do what is good in your hands. Recently, Yamane technique has picked up very well, and many of the surgeons have shifted over to Yamane technique. They are doing it because they don't want to use glue and other things. They don't want to do peritomy. It's a closed chamber kind of thing. Works very well. You can do it what works well with you. I have done glue dowels maybe for the last so many years, so I tend to do this because I tend to get minimal complications with this surgery. The tilt is less, etc. So I try to go ahead with this surgical procedure. Clear-cut lensectomy is done for this case. The only thing is that, you know, you should know how to go ahead with these kind of cases. You know, you need to make a sclerotomy site. It was shown before by Dr. Ghosh. He also showed you make a sclerotomy site beneath the scleral flaps. The most important thing is you need to have a fluid infusion inside the eye. You cannot do the procedure in viscoelastic. At no point of time your eye or the globe should collapse. So fluid infusion is a must. It should go on. You can use an anterior chamber maintainer. You can use a pars plana infusion. Whatever works well with you, you can do it. But you need a fluid infusion going on inside the eye. You clear up the entire lens. It's a soft lens. It comes off very easily with the vitrectomy probe. Vitrectomy probe works best because it keeps on cutting the vitreous and it keeps on sucking away the cortical matter. So at no point of time you are inducing any traction. So the next thing is doing a glued intrascleral fixation. This is a 3-piece foldable intraocular lens which is loaded. You just hold the tip of the haptic, that what is being shown here, and you wait till you know, the entire intraocular lens has unfolded inside the eye. Once the entire intraocular lens is unfolded, then you pull the tip of the leading haptic. So then the leading haptic gets externalized. Now, you know, you have to manage with the trailing haptic. So you flex the trailing haptic inside and you move this, and then you can just leave your trailing haptic, the leading haptic. It does not fall back. What you just saw was a handshake technique. It's the transfer of haptics from one hand to another because you need to externalize it from the right side. So now both the haptics are externalized, and then you go ahead, you can, I always suture, I always consider suturing the corneal incision because these are vitrectomized eyes. You don't want any leakage coming up from any point of time, and then you just tuck these haptics and you are sorted. Tucking of the haptics is very important. Let me emphasize, about 2 to 3 millimeters of tuck of the haptic should be there. So because that is where the stability of the intraocular lens comes. Glue gives only a self-sealing kind of effect. It does not hold the intraocular lens. So that's very important, how much amount of haptic you are tucking, and then you just seal it and you are done with that, and you place the fibrin glue and you are done. So I'll just sum up this. If you have a total kind of thing, again, you need to go ahead with, you know, thorough vitrectomy and intracellular fixation. I'll just show you this in brief, just a 1 minute. The handshake rebating method. This is the adaptation of the Yamane method, and what you see here is, you know, this is what you need for this is a 26 gauge needle and a 3-piece intraocular lens. We do not get many times 30 gauge needle here in our country, so we just modified this a bit, suiting to our scenario. So what actually is done is that the initial steps are same like what we do in a Yamane method, 2 millimeter by 2 millimeter. You just mark. Then with a 26 gauge, you take a long needle. You take a 1.5 inch long 26 gauge needle, and then you create the track and you externalize the leading haptic. The only thing differently that is done here is that, you know, when you make a flange of the haptic with a low temp cautery, you just compress it. So that's called rebating. You compress it so that, you know, your haptic does not slip back inside the eye. So that's the only thing. Why it is done? Because, you know, 26 gauge, it creates a much more thicker track as compared to a 30 gauge needle. So if you create a bulb, the bulb of the haptic, it might slip back. So in order to prevent the slippage, you can just rebate it, you can just compress it, because at that time it's hot, and you know it just gets compressed, so it does not slip back. So this is just a small little modification. I'll just show this video if you're interested. This is how the 3-piece intraocular lens goes in, and you can just thread the leading haptic directly into the barrel of this needle. So this goes in, and then you just externalize this haptic. So this is the leading haptic that comes off, and then with the low temp cautery you'll just create a bulb. You can even, if you actually do not have a low temp cautery, you can even use the ballpoint cautery, which we always had previously. You know, you can just heat up that ball, and with that ball you can bring it closer to the haptic, and then the flange automatically comes off. One other point I would like to say is that the flange with the PVDF haptic is better than with the PMMA haptic, because the sensor 3-piece and all these are all PMMA haptics. They are not PVDF. PVDF haptics, actually they are not available. CT Lucia lens from Zeiss, I have no financial interest, but it's not available. What you see abroad, all the surgeons, they are using these PVDF haptics. They don't use these intraocular lenses. So the kind of haptic bulge and the flange that you create with these lenses is going to be different than what you can go through a paper which was published by Dr. Oliver Fendel. He has published the different types of flanges that are created with different types of intraocular lens, depending on the material of what the intraocular lens is. So it's available. I think it was published in JCRS. You can go through it. For the benefit of time, I would just like to end up here. But this is how, you know, the things are there. Thank you so much.
Thank you, Dr. Priya. The main problem I have with you is you make this look so easy, and then we try it and we land up in a soup. I have a question for the last technique which you showed, the flange technique. What if we cannot directly, you know, while injecting the lens, guide the leading haptic inside the 26G?
Yeah. So this actually what you saw was described by Dr. Brian Kim. If you cannot do that, it's fine. You know, many of the surgeons, they don't actually dilate the pupil much when you are going to do a Yamane kind of thing. You unfold the entire 3-piece intraocular lens onto the surface of the iris.
Okay.
That's the best thing to do. So your entire IOL is inside the eye. For safety purpose, you can keep the trailing haptic a bit outside the cornea, outside the corneal incision. That's what I mean. And then you can go ahead with the leading haptic, and then you can manipulate it. You go from the needle from this side.
The space is not an issue. The space is not an issue.
No.
Okay. Excellent.
From Dr. Sudipta.
The first case that you showed was a bit of subluxation, not much. For a beginner, I'm asking, that before putting a CTR, can a capsular look in that? Yes, it can. If you find it's dangling too much, yes, you can.
And then you go on with the complete surgery, and when you have
Absolutely. Yes, yes. You can use at any point of time. Wherever you find something is going.
the device is bulky for it.
Absolutely. It all depends. Yes, it all depends on what is there at that point of time. So you can handle it accordingly to your comfort zone. Yes, definitely. Why not stabilize it? If it's moving too much, it's definitely advisable.
Dr. Narang.
Do you always make those 3 and 9 o'clock TIs that you make?
Yes,
We usually make it for very high myopic eyes, big eyes. We do it because these eyes, they have a wide to wide diameter of about 13 millimeters or more, and our IOLs are not that big. So because of that, the companies are not making 14 millimeter IOLs for us. But this is how we came up, and we have published this also in JCRS. You know, you make these sclerotomy sites a bit anterior. But point is, when you come a bit anterior, you know, there is a tendency that when you make a sclerotomy site, you will drag the iris tissue because you have come anterior. You are not behind the iris. So that is the main contention. To avoid that, you do a peripheral iridectomy so that when you are entering inside, you do not drag the iris tissue and you do not cause an iatrogenic iridodialysis. So that is the concept behind it.
Yeah, for the tucking, are you using 26G needle or 27 or any other needle for tucking of the
26. We use 26. But I have seen many people, they use a normal sclerotomy, the MVR blades also, and they are making it. But we use 26.
Is it enough to hold the lens with?
Enough. It is enough. 26 is enough.
Yeah. Thank you so much for the excellent talk, which is a very good learning point.
We have
Thank
a question there.
Oh.
How far do you make the sclerotomy port from the limbus?
It is about 1 to 1.5 millimeters. Depending, if the eye is a big myopic and a big eye, we might come at 1 millimeter. So that is where we do a peripheral iridectomy. There are two things we do. We come more anterior, that is about 1 millimeters instead of 1.5, and we do a peripheral iridectomy so that we don't damage the peripheral iris tissue and we don't drag it with the needle.
And ma'am, second question is when you put a CTR ring in the subluxated lens or the capsule, so where the area of subluxation, for example, in your case, it was probably considering the right eye, it was inferior temporal quadrant. So would you prefer putting the ring in that quadrant the first or the last?
The ring is almost like it covers everything, so there's just a very small gap that is left out. So that's fine,
No, I mean, if there is more subluxation, for example.
Then you have, only a ring will not suffice. You need segments then. Then you have to use endocapsular segments. So then you have to fix them with the sutures. Everybody, I think, I don't know if Gore-Tex, everybody is having it, but they are using the sutures. These days, what has picked up is, the Sergio Canabrava's flanges. He uses a 5-O-proline. If you are using a segment, and through that hole, you just pass your proline, you bring it out, make a flange, and you are done. So you're not struggling with any of the suture inside the eye.
Thank you.
Yeah, thank you.
Thank you so much. Thank you. So our next speaker is Dr. Shuja Gupta. He's a prolific surgeon who actually does surgery better when there is complication, because he creates complication and manages them so well. He's a very good surgeon. So he will be speaking on his agonies and ecstasies in managing ectopia lentis.
Thank you, Dr. Paul, for giving me such a wonderful introduction. Now, the difference between a genius and a fool is the difference between my previous speaker and me. You saw genius, now you will see fool. The problem is, if you don't attend instruction courses and just see videos and then try it out, then these are the bouquet of cases which is going to happen. So in my first case, this is a young male patient, traumatic cataract. You can see a fairly decent amount of subluxation. Try to go and try to do rexis. Completely forgot this is an elastic capsule, though the elastic capsule started running out. Anyway, we managed to get the rexis done. Cataract removal was not a problem, soft cataract. So now go in for implantation of the CTR. Now the CTR kept on slipping out. I didn't know why it was slipping out. I thought maybe my angle of insertion was not correct, so I tried to go in more vertically. Can you reduce this music a little? So, but it still kept on slipping out. So then I decided, okay, maybe going in through the main port is not a good idea. Let's go in through the side port. So I went into the side port, but there the angle of attack was so acute that it was pushing the hole back to the other side. I tried a little more, but still it simply wouldn't go in from this side. So now I go into my fallback method, which is going in through the last hole left in the eye, going through the other side port. Going through that, try to dial it in, looks promising by the way. The main problem was, if you notice, that the rexis is centered to the pupil and not centered to the lens. So the overhanging edge is so close to the equator here that the CTR kept slipping out. This overhanging edge is not enough to support the CTR. So that was my first mistake. It's another case. This whole area is subluxated. Old case. This is the lens is fibrosed. The patient is an old, poor patient. Because of financial problems, he could not get his eye operated. You can see the anterior capsule is also a little fibrosed and thickened. Bare minimum movement of the lens, even with such a large area of subluxation. Even with a sharp cystotome, you could finally manage to lift up a flap, support the lens with a second instrument and go in with a rexis. I did not use blue in this case because I thought the blue would go mostly inside the vitreous and I'll lose all the glow, if there is a glow. Rexis was easy, so I learnt my lesson from the previous case, implanted the CTR early on. CTR is good. This is a technique I learned. You can hydro the bag from inside to stain the bag. Now I did this to put in hooks to stabilize the nuclear bag complex more. So I used all different types of hooks, to impress people. Multicolored options are here. Technique for phacoemulsification has been described innumerable times. Slow motion phaco. Yeah. Okay, they have asked me to slow down the music from here. I don't know how to do that.
It's in the volume.
Yeah, so, yeah, I'll close. Yeah, so I've stopped the volume, fine. So, to come back here, okay, so I've hydroed the bag. The video is not playing from here.
So, Surya's first case shows that you need to off-center the rexis so that when you actually fix the bag, it comes in the center, which has Shuja shown.
See, important of keeping CTR in place, you have to have at least 2.5 millimeter equator from the capsule rexis margin to equator, at least 2 to 3 millimeter, 2.5 to 3 millimeter, otherwise it will slip.
Okay, so
so these particular cases, this is ideal for Sioni ring, not CTR. If you don't have able to make a good, most of the time it can happen, you're not able to make a good equator, then it is time for CTR. Otherwise, you can combine CTR with Sioni, IMS segment.
okay.
Yes,
Okay.
Surya,
Yeah.
start.
There's something wrong with this. नहीं चल रहा भाई. Yeah, I think I'll do that. It's better. इसको escape करके निकल जाते हैं. ये hang कर गया. Actually, this is hanged. छोड़ दो. I'll play. There are 3 videos. I'll just play the video separately. आप छोड़ दो. I'll play the video separately. Okay. Yeah, so we were here, I think. Yeah, so I've hydroed the bag. This is a good technique I have learned, that you can hydro the bag, it'll stain the bag from the inside. So you can see the bag is stained, you put in the hooks. The phacoemulsification is fairly simple. And you lower the bottle height, reduce the vacuum, no sudden movements. You don't already want to damage the damaged zonules. So you're going in with phaco and the broken down the nuclear fragments into small pieces. And you slowly remove the nuclear fragments. You have to be very careful because there's a large degree of subluxation here. Now the advantage which was working in our favor here, fortune favors the brave, was that this is an old case of subluxation. A lot of fibrosis has happened in the periphery and the bag was hardly moving. So I have removed already the 2 hooks in the area of zonular presence. The only dehiscence, the zonules are, hooks are there. And I implant a single piece lens. You can see there's absolutely no movement of the capsular bag. So then now I have realized that this bag is quite fixed and fibrous. This is not going to move. So we leave it at that. And thankfully, by the grace of God, it stayed on like this. This is another 3rd case where I had put in blue. And you can see it has gone inside the vitreous. And there's absolutely no glow. Actually, it was a small pupil. So after small pupil, when we started operating, we realized that this is a case of spherophakia, grossly elastic and small capsular bag. So the implantation of lens was very difficult. Now you have to remember, these are the times before the intraocular devices like B-Hex or Malyugin's ring. So after I have already implanted 4 hooks, I am loss of instruments to stabilize the bag with another set of instruments. So it was quite a difficult situation then. Now, another of my agonies, traumatic case, I have put in 4 hooks here to stabilize the bag. Fairly soft cataract, not that hard. Going for slow phacoemulsification, I decided to put in a CTR at a later time because I did not want cortical entrapment and what not. Phacoemulsification was going on decently, not much of a problem. But see, now just pay careful what happened. Could you make out what happened? The posterior capsule was flapping like a flag in the wind and I caught the posterior capsule and I completely ate it up. So in spite of putting in so many hooks and stabilizing the bag and everything, I have lost the posterior capsule, so there's no point in continuing the surgery right now. I should have put in CTR ring here. See, if you put in a CTR, not only it stabilizes the bag, it also makes the equator taut and the posterior capsule tight. So it doesn't keep on flapping. So if you have a posteriorly directed phaco probe, during active phacoemulsification, it does not pull the posterior capsule inside the probe. So this is another of my agonies which I have learned. It's better to put in a CTR early on. It tauts the capsule, it tauts the equator, and it tightens the posterior capsule and flattens it. My last case, see, I have screwed up at every stage, so don't worry. This is a stage where everything else went on fine, vitrectomy done, time for scleral fixated IOL. I cannot do glued IOL. These are my earlier cases, so I am doing a scleral fixated IOL. Straightforward said, tie the sutures to the SF IOL. But see, the main first mistake, I have not put in any sort of chamber maintainer, either a posterior chamber maintainer or an anterior chamber maintainer. Because this is a secondary IOL, vitrectomy was done, I thought maybe I will not put in any sort of posterior infusion. What happens because of that is the IOL keeps on tumbling inside the anterior chamber. Basically, some sort of trapeze artist thing is going on with the lens here. Finally, we could stabilize the lens by pulling on both the haptics, but then the second problem cropped up. The suture caught the undersurface of the iris here. You can see there's a notch here. You can see the pigments are coming out. I'm trying to guide the haptic more towards the scleral fixated site. It simply wouldn't come out. The undersurface of the iris has caught onto the sutures. I try to separate it with the help of viscoelastic, but still it's kept on getting caught. Finally, with the help of an iris spatula, we could dilate out of from the undersurface of the iris. So the lens is stable, tie on one end, things are looking nice, make a good knot. Now the part of trying the knot on the other side. So I do a triple knot, I'm pulling and tightening, so trying to do a second knot, and then I realize something is wrong. Now what is wrong? I have torn off one end of the suture. So now I have a scleral fixated IOL with one triple knot holding one end of the haptic. So now I'm thinking what to do. Again, thinking time, hydro the side ports, hydro through the main port. I decided let me suture the main port, at least stop leakage from the main port and the chamber shallowing. I still haven't put in any sort of chamber maintainer. Big mistake. You should have put in, makes surgery a lot easier. So I decided that I'll try an anchoring suture with the floor of the sclera, and then I'll tie that anchored suture to the remaining suture which is already there. You have to remember one advantage, that the suture is already tied to the haptic, so it's just not just looped with the haptic. So when I was taking the bite from the floor of the sclera, just see what happened in slow motion. This is the remaining suture. I, by mistake, had caught it while holding the flap of the sclera, and during taking the bite, had torn off a part of the scleral flap with the remaining suture also. There you can make out I am tearing it off. There. So now I have a single triple knot holding the lens in one side. Now what to do in this situation? I tap the lens, I decompress the anterior chamber, fill up the anterior chamber, tap the lens. I realize the lens is stable. We decided to let it be like this, evaluate the patient on the post-op day, and see if the lens doesn't move, leave it. If the lens moves, then we can plan something, removal of the lens and secondary, third implantation rather. But thankfully, the patient was followed up for quite a little bit of time, around 5-6 years, then got lost to follow-up, and the patient did well, probably because there was a triple knot tightly embedded inside the sclera. So these are my agonies. I have learned from my mistake. The main thing is, first, always use some sort of chamber maintainer. It's very important. Second is, I prefer implantation of the capsular tension ring very early on during the surgery, whether you want to use a Sioni segment or a Sioni's ring, whichever. And thirdly, it's very important to stabilize the bag even with CTR with with hooks for a large degree of subluxation, because hooks are not always, a CTR is not always enough, and hooks are also not always isolatedly enough in cases of large degrees of subluxation, especially traumatic ones, where you're not sure how many zonules are partially damaged. Thank you.
Thank you, Shuja, for taking us through.
I would not like to leave the lens, the haptic like this. If it was not, you are not sure that it is there in the place, you should have not. You can retrieve it again, get suture it, and get definitely suture in the sclera. And I advise to all scleral fixation people that please make a large flap, quadrangular large flap for scleral fixation, so that you have enough space. And then I give the last suture under flap of the flap, so that this suture sits down on the bed itself, and it never moves. In fact, after 1 month, 2 months, you will find that it is a phaco. It's not even a scleral fixation. You won't find any mark anywhere.
Yes, sir.
So I advise everyone who's trying scleral fixation that if you want 100% surety for life, then make a large flap.
Yes, sir.
Scleral flap, 4 into 4, and then take 1.5 millimeter away from limbus, the out suture, and then under last flap, last knot should be under flap of the, underneath of the flap, so that suture, the flap never get displaced and knots never get exposed. That is the biggest problem of SFI.
SFI, yes, sir.
Exposure of the knots and the infection going in the eye.
Yes.
Thank you.
Yes.
Thank you, sir, for those lovely
My name
inputs
is
from your.
KPS Malik.
Yes,
Yeah,
sir,
you know, sir. So
we
that's
all know,
why,
sir.
from those years of experience you have given, sir. Yes, sir. Yeah, we now move to the master blaster, Arup Bhomik. I mean, he needs no introduction. He is the winner of all the American ASCRS, ESCRS awards for the best challenging cases. So he will be talking to us on extreme subluxation. Yes, so, Arup, please.
Thank you, Dr. Paul, for giving me the opportunity. And my my topic is extreme subluxation. So there's a what are the traumatic subluxation is basically a localized loss of zonule or generalized loss of zonule, but when there is some kind of disease process, there is a general loss of pupil. So for strategically the treatment and surgical planning should be different. The strategies most of the surgeon follows, it is less than 90 degree, then only put the CTR. It is more than 90 degree, we need to fix the capsular bag with the sclera, or now we have another technique, interscleral fixation. I'll show if my permit. The operating surgeon is the ultimate judge how to proceed, and it is surgeon should be very flexible to dealing this cataract and should be prepared to handle greater degree of difficulties during the surgery. So as Shuja shows, different problem in every steps, you can face difficulties. So in clinically, if you find in OPD it is just less than 90 degree, but in OT you find it is subluxation is more than 180. So be prepared to handle greater degree of difficulties in this particular type of cases, and factor this may complicate this scenario. Subluxation is hard cataract, shallow AC, vitreous in AC, and hypermature cataract. So vitreous in AC is utterly important to deal the subluxated cataract. I think Dr. Siddharth also covered this, how to deal the vitreous. It is just so for a small note, you have to limited vitrectomy, put a capsular hook, and then do the vitrectomy. This is should be very limited. Otherwise, if you do the big amount of vitrectomy, do the much vitrectomy, then the support of the vitreous give the support of the nucleus. So then support will be much less. So limited vitrectomy after putting the capsular hook. So this is the important stage. I am going to the one stage, and as Dr. Ajoy Paul told me, just finish your case within 1 minute, and it is a big subject. So now the most important part is rhexis. So once there is a don't mind to change your position. So I always prefer to do surgery in the proceeding in the temporal position, but as I saw that there is a subluxation is slightly different pattern, I go to the superior position. I started, and now the rexis, the most of the extreme subluxation, the lens, the half of the lens behind the iris, so it is very difficult to do visualization, and this kind of Marfan syndrome, you will have a very minimum traction in the capsule, elasticity will loss. So it is better to make half a rexis or 4 clock hours, then put a hook to keep the stretch the anterior capsule margin. Otherwise, not able to complete the rexis. It will always run away. So make a traction into the capsular rexis margin with applying one hook, so that you can able to complete the surgery. I am just skipping this video. I am just concentrating one video. This is enough subluxation. I thought it is enough. This is most of the zonule. This is a laxity of zonule as well as the loss of zonule. So planning how to fix this case with this capsular bag. So first of all, I'm making a Hoffman pocket. If you don't want to do a Hoffman pocket, so you can cut the conjunctiva, cauterize that, and make a flap. You can tight your for beginner, I will rather prefer to do a flap, large flap as I said, and make a under visualization, tighten the knot. So this is a Hoffman pocket. I always mark Hoffman pocket with marker pen, so that I can rough assessment how we pass the needle. So this is a Hoffman pocket. So then the next stage is rexis. As I said, I try to make a flap, and always remember I have to keep at least 3 millimeter from the equator, so that my CTR will not slip off from this. So I make a rexis, and now I am feeling there is some kind of loss of traction in the anterior capsule, and it will hamper the visualization. And now I putting the left hand Kuglen hook, hooking that margin, and it will give a little bit of pressure into the rexis, and now it is much easier to do the rexis. Much easier to do rexis. You have to put some kind of traction force into the rexis margin. This is the most important stage, rexis, and sometimes you will get case that there is so much of loose capsule not able to puncture then the railroad technique. Railroad technique basically 2 needle, the straight needle, straight forward, and puncture the anterior capsule. So, but here I am able see there is a loss of traction whenever I go to. Then now it is very careful to complete the rexis. I always keep in mind there should be at least 2 millimeter. Now stabilization of the bag. Next stage is stabilization bag, and stabilization bag is a 2 type. If your horizontal stabilization is stabilization putting the capsular tension ring into the bag. This is a horizontal stabilization. And if your anterior posterior stabilization, that means you have to stabilize the capsular bag with the limbus. That means you have to put either iris hook or capsular hook. Then and timing of the CTR, as I said, this is very important. Timing of the CTR as late as possible, but as required it should be masked. So I always prefer to put little bit later. Say in this case, particular case, there is a softer catheter able to phacoemulsify. Now I remove. This is a phacoemulsifier. Now I remove all the hook from there, dislodge this, and get a clear space there. And unfortunately, in our country, we will not get double-armed ninoprolene. Tenoflurane is available double-armed with straight needle, but for ninoprolene, you have a single arm with one bent tip.
Getting straight.
Is it now available?
Yeah. So
okay. So recently, this is my old video. Recently, I using Gore-Tex suture in every cases. Yeah. Yes. So now you can puncture again, and pass the needle from this. This is a beauty of Hoffman pocket, because everything here will be under the sclera. I'm just little bit forwarding this and pass it, and now I'm putting that CTR. Then arm edge segment, and it is attached to this under the suture, which is under the scleral flap, and cut this, remove this from extender from the flap. I put the lens into the bag before tying and after the tie, so that I have a rough idea how much I tie, and it is give a better centration of the IOL. So I'm just removing this new cases, my new thought. This is extreme subluxation, and this is extreme subluxation. I am planning for interscleral fixation. So it's very difficult to do. As I said, the very difficult to get a puncture even in the whole lens is subluxated. So I able to make a rhexis, and the same procedure. There is a phacoemulsification is a big challenge in the hard cataract in a subluxation. So I have to put 8 hook. I have put 8 hook here to stabilize the capsular bag, and now it is remove the one chunk. If you remove the one pie, then it is very easy to do, relatively easy to do. And once I able to phacoemulsify, then the whole lax bag is there. Then I just modified glued IOL technique, and I bend the tip of the acris of multi-piece and tied with the suture. I remove this, and I called it is a ECC glued IOL, and because bag is in the place, generally what we do, we fix the capsular bag and implant the IOL into the bag. Here I am fixing the lens and capturing the optic of the lens into the bag. So I am doing here reverse. I am fixing the lens and capturing the bag so that it is stabilized. So this technique I am doing, and tell me, this is getting this wonderful results. The same thing I am doing, the fixing the lens and capturing this with the bag. So whatever thing, you have to fix the one thing, either lens or the capsular bag stability. Thank you so much, Dr. Paul, giving me the opportunity.
Thank you, Arup, for showing those amazing surgery. I mean, that needs amazing, I mean, you need to have that, proficiency. And over the years, I know you have gathered that, and especially the last technique is something I have been looking into it, and this is definitely the way of thinking, that not putting the lens in the bag or fixing the bag or putting the lens in the sulcus. That's what I'll be saying. Well, thank you, and we will now come to the next topic. Well, the last topic. Dr. Chitra would not be able to make it as she's got busy with somewhere. Yes, can I have it? So we are talking, speaking. I think I have 10 more minutes or 15 minutes, as we had overshot the time. The earlier we got it 15 minutes late. So can I have the? I'll be talking on emerging femtolaser technology for subluxated cataract and devices. Is it a boon or a fad? यहाँ लगा देता हूँ. Yes. So here we are. So you saw the the problem with the rhexis, the pitfalls in subluxated cataract. You have to hook it, you have to wear, especially the ones that are too much subluxated. And that the advantage we know of femto laser, the biggest advantage, the rhexis so pointed. And the capsular supporting devices that we have seen over the years, the paper clip, the RCS paper clip, but these are the ones, the Sioni rings has stood the spread, the test of time, and we still go on using. The sutures have changed to we have the Gore-Tex sutures now. So Sioni CTR remains the standard of care, and tenoprolene, and this is the standard that we are using now in all our. So long-term stabilization of capsular bag is important, other than putting the lens in the bag. So these studies have definitely proved. The first Dr. Chi had said the management of severely subluxated, she got 90%. Normally we get it around 60 to 70%. We could do it, but with the femto laser, you get 90% success in this. And this is the study by Dr. Tetial et al. They have also shown that the success of the use of femto laser in subluxated cataract, again one more study. So this has come to sit. So let's come to some videos. As you know, this is a catalyst, and you can see the subluxation there. So I'm fixing it here. So I saw around 90-degree subluxation, and I've just gone and done the rhexis. So you have to bother about the tilt. Now this is the case. You can see the subluxation there. I had already prepared, I was not prepared for a subluxation, so much of subluxation. So I had put a subtenon anesthesia. So there I'm going, and I am one of those person who puts CTR very early. Rather, the first I do a visco separation and put in the CTR. So I just want the bag to stabilize right in the beginning. So once I have got that bag, so that the femto laser has already made my nucleus disassembly so easier. I can get those. So this is a bubbling lens and nucleus. So I get it right well centered. This was a 90-degree subluxation. So I thought that I need not put any. See, once at the end of the surgery, I just tried to see what is the rhexis. Rhexis is right, and this is not a progressive because the patient gave a history of trauma. So this was supposed to be a trifocal lens, and we continued that way. The other eye had a trifocal lens already, and this trauma was not seen preoperatively. I mean, this one is dilated, but the PI actually, the LOI, the pressure that's revealed us that there is a subluxation there. So this patient is already 9-month-old, and we are still following the patient. The lens is well centered as of now. Now this is another second case where femto laser we are using. Look at this, the subluxated area. As you'll see, there is a small iridodialysis. This is again a traumatic cataract. The tilt is actually it corrects almost 5 degree of tilt or 10 degree of tilt. Most of the machine would correct. So you see the subluxation there. So we are moving it the other side. This is the temporal side, and we can just the femto laser gives us the rhexis. You can place it as and where we want to place it, and so once we have done that. Now this is the situation. See, we already have almost 180-degree subluxation. So once the subluxation, you can see I've already prepared a bed for doing a Sioni. I generally use a scleral groove there instead of a Hoffman or a scleral any flap. So there I take out the. So you can see that since there is a tilt there, so one has to be very careful of removing the rhexis. There have been cases where the rhexis has run off in subluxated cataract, but here I'm trying to remove it. See, gradually, as I can see, there is a subluxation almost 270 degree, but still I continue. This is a stable subluxation. So once I do that, I put 3 or 4 hooks there, and there I get it and round and do a bit of hydrodelineation, dissection, and get those pieces out. Once I get this pieces out, it becomes easier. Now, how do I put in the lens? In this case, what I did was, as you can see, I put only the CTR, so the removal is just by using sideway traction and the tangential traction, and you can remove it. So there we can get the, and you can see I complete the axis. So I find this quite central. The whole the CTR has actually made it central. There was a history of trauma in this case, so I go on put this multi-piece lens in the sulcus with capsular capture. Now this is what we are talking, that we are trying to change the wave, and in this case actually we did not put any supporting device, and we are sure that this would stay, and this is under follow-up almost for 2 years and is still maintaining that support. And this is the last case we'll be showing. See, look at this. This is again subluxation there, and I have put the rhexis as this is again an young Marfan guy who had a trauma. So there is a traumatic mydriasis also in this. This is what. So I have some dot here. So I know that the rhexis is not complete because the tilt was quite appreciable, but still I could get now with the femto laser. Even I have, normally we put around 500 micron, both anterior and posterior, but in this case we had put 800 microns, so it had gone quite deep also. So we got the cuts, the rhexis cuts as we desired. Once that we have got, I'm doing a hydro visco delineation followed by the capsular hooks. I just support it because the subluxation is at this side. I do again visco delineation just like I would do, and then as I said, I am the one of the person who puts CTR very early because I feel very safe putting the CTR, and once I've got the CTR there, I know I can remove those lens nuclear pieces because those have been already disassembled by the femto laser. And so once I've done, see, this is a trauma, so there is a lot of vitreous there, a little bit of vitreous protruding out there. So once I go and remove that, I can see that this definitely needs a support now. So I go in, as my earlier speaker has shown, going with a Sioni ring, the CT segment rather, already the base there. So the two sutures there, I do a scleral groove, and the same way I just go in, put this CT segment, and there the CT segment goes in. Once that is goes in, I remove the remnant of the cortex there, and once that cortex is removed, I just put the lens in the bag in this case because I've got the CT segment there, and end the case with a little bit of vitrectomy. Actually, this was a mydriatic case. Ultimately, in the next stage, we had done this patient a single pass 4th row technique of keeping the iris because this is a mydriatic 6 millimeter dilated pupil. So in the second stage, we did it. As I just not showed in many times that this is an extreme subluxation. See, this is what we have done, 3 and 4. And in this case, at the end, by the end of the surgery, I had lost the capsule, but still I did go on with a big PMMA lens there, because there was already sulcus support, so went ahead with it. Thank you for your patient hearing. And since we come out of this end of this course, yeah. With the femto.
If you have an incomplete rhexis
with the femto in a subluxated,
how do you complete the rhexis? Is it different
it is
from
not
how
difficult.
you do the rhexis normally? Or
yeah, it's the same way normally, because that wherever the tilt is there, because now we have an option of do almost 800 micron offset. So if the tilt is there, it will still fire below it and above it. And most of the time you can do it. We can manually see it. If the tilt is more than 15 degree, normally you cannot do. So 5 degree, 10 degree tilts, it can be managed. And if the rhexis is incomplete there, you can just take capsular rhexis forceps.
Pull is towards the center or
pull
normal?
Is towards the normal towards the center as you do. Just because there would be some marks. It's not that there is a skip. If it skips, that means the tilt is too much. So that we do actually pre-operatively. And if you see the tilt is too much, normally you would not go. Yes.
Thank you.
Thank you.
Sir, a preloaded CTR
yeah.
is easier to put or a manually?
Mike.
See, preloaded CTR is definitely would be advantageous, but with the manual, you can, I mean, most of us are trained into manual, and the preloaded, you would not be, at many times, would not be able to control. Now, once you are put in, then again pulling it and pulling, I mean, it's a bit of practice, but a lot of people do with the preloaded. We have got preloaded now as at low cost also, because the earlier injectors are very costly, the preloaded ones, you can try it.
So even with the nucleus inside, it is easier
Yes, it is. Yeah. If it is grade 4 nucleus, you don't have space, it is. But I'm one person, I would do it very early. I mean, I feel comfortable, and I have seen my earlier cases were always after removing a little bit of piece, and I have seen that I have lost those nucleus in this bag. So I do it very early.
Thank you, sir.
Thank you.
We feel CTR is one of the few things that it's better not preloaded. CTR is one of the few instruments which is better not preloaded, rather inserted manually. First of all, you've got choices to go in through various ports. You can create a port, as previous speakers have mentioned, to get a better angle of attack. And secondly, as he mentioned, there's so much of manipulation required while guiding a CTR in an already compromised bag. It's better to have a free CTR where you can hold both the hands and guide. I personally feel that CTR is better off without getting preloaded.
For the beginners, will it be easier to put some sutures in the eyelets of the CTR? So if it goes wrong, you
that's something, again, when you are doing CTR, put an eyelet so that you don't lose it where it goes, especially in a compromised. Here you know the rexis is okay, you can still go in, but in a compromised where you have a zolunar dehiscence during the surgery, you do not know whether this CTR or there is a rexis tear somewhere here, so it's always better. Anyway, thank you, scientific committee. Yes, you have a question? Yeah.
Yes, sir. So my question is about the secondary glued IOLs. So what is the technique to prevent the haptic exposure? Like we have seen some cases in which post-surgery, maybe 3 months, 4 months later, one of the haptic just stuck.
It depends on how the, I've been doing glued IOL for less, I've also had cases. I have used, it depends on how thick or thin the sclera is. If the superior scleral BA is very thin, it normally melts, and because the eyes, whatever you say, the lens would move. So it's better, and you can do a scleral graft over it. I have put scleral graft over it from other side and covered it with it. Thank you. Thank you, the scientific committee. Thanks, everybody, all the audience here to be in our course. And thank you, Mike. We have made up the time because you got it 15 minutes late, and since we got it, and I thank my co-instructors, Dr. Shugoto and Dr. Shuja, to stay till the end, because the other ones had to go to other session. Thank you.
Thanks a lot.